health. And that speech of his, we've recorded it, and then we will be putting it on our website. If you're a journalist and you wanted to access it afterwards, it should be on there by tomorrow or the day after that. But this conversation that we're doing now is live streamed, and there will be a recording that will be on our website later today. So to start off, we know now, after Yogan so eloquently pointed it out, that the biggest health threat that we face for this century is climate change and its consequences. And it will have an impact on virtually every aspect of health. So to discuss this, we've got 4 panelists, and they all work in different fields of health. I'm going to introduce them as they speak in the interest of time. Going to start off with looking at what the impact of climate change would be on the spread of HIV. And I would love to start off with you, Kingsley Orievulu, who is a social scientist at the Africa Health Research Institute at the University of KwaZulu-Natal. Now, Kingsley, you've been doing research specifically on what would the impact be of floods and of droughts on adherence to HIV medication. Can you give us an overview of that?
Thank you so much, Mia. So I will start off just by saying that experience working with the KwaZulu-Natal, we worked, I think we looked at drought and its impact on HIV treatment adherence among people living with HIV. And one thing we found in our study is basically the fact that the dimension or the mechanism is not necessarily linear. It's a very complex interaction between climate change generally and HIV outcomes from infection down to ART. So in our study, when we spoke to about 27 people living with HIV, we were able to identify different pathways. So beginning with socioeconomic pathways, where you found that the drought affected people's livelihoods. It affected people's access to employment as well. We also had situations in which a lot of people lost their livestock. A lot of people struggled with food security. And in all of that, what happened, what we basically solved was the fact that the drought in this instance affected local people's contextual vulnerability, and that mirrored into their ability to maintain treatment. And so what you find is that people who were in care, or people who needed to be in care, had different things to think about beyond trying to get treatment. So they had to try to get water for themselves because their taps were broken, the community taps were broken. They had to source their own, try to find ways to get money to take care of themselves. And in many situations as well, people had to wake up, especially women had to wake up very early in the morning to go look for water because their water sources were difficult. They were not able to get water, and many people missed appointments. So in terms of the relationship between climate change and HIV outcomes, first of all, what we found that the impact on people was in such a way that it made it difficult for them to be able to take care of their immediate needs. And in a context like KwaZulu-Natal and the context in which we studied, you find out that people became desperate, and some people were also forced to engage in transactional sex, mainly women as well, because in such a situation, people were faced with a desperate situation where they had to make their ends meet. And such situation made it difficult for those who were in treatment to maintain treatment. And when people are unable to maintain treatment, they then run to the risk of falling out of care, and then the risk as well from drug resistance. And when you face that situation, that also heightens the risk of infection within the surrounding environment, because people who are engaging with these people because of the needs of their problem. They also run the risk of higher infections.
Thanks very much, Kingsley. I'm going to use your mic because this one makes a noise when I put it on. So just to summarize what you've said is, when there are droughts and when there are floods, people are stressed out and they don't necessarily adhere to their treatment. But there is also an issue if there are floods of how will you get your treatment, right? If you don't have an ID card and that was perhaps washed away in a flood, then you can't adhere to your treatment. And if you don't take your treatment, your ability to infect another person becomes far, far higher. To move on to Yogan Pillay, who is the Director of HIV and TB Service Delivery at the Bill and Melinda Gates Foundation. Yogan, what happens to TB? Will TB spread faster? We've heard that HIV will almost certainly spread faster because people wouldn't be able to adhere to their treatment and access it. But what will happen to TB and other respiratory diseases?
Mia, thanks very much, and good morning, everyone. So I think the first point to make is that we know what the risk factors for TB are. In the report that will be released this afternoon, you will find that undernutrition is probably the biggest risk factor for TB acquisition, followed by HIV, followed by alcohol disorders, followed by smoking, and followed by diabetes. Now, and all of these, of course, could be affected by climate change. So the risk factors are, they're going to be the trigger for increasing TB prevalence in countries. So what we expect is more and more people are going to be impoverished, and especially people in low and middle income countries where conditions of life are not resilient. So where you have lack of resilience in communities, you're going to have a bigger impact on all of the risk factors for TB. So one saw during the cyclones in Mozambique, cyclones in Malawi, etc. And if you also look at the flooding during the winter months in the Western Cape, you will see lots of people moving from their homes, which in themselves are inadequate in terms of indoor air pollution because they are using poor quality coal to heat up and cook and heat up the house and cook food and whatnot. So you'll find increasing indoor pollution, you will find overcrowding, and that's the context in which TB spreads. It's been long said that TB is a condition of poverty. Poor people are more likely to contract TB than anyone else, even though anyone can contract TB, but it's more likely in the context of poor nutrition, overcrowding, being HIV positive, and of course having diabetes. Now, we don't often think about the relationship between diabetes and TB, but with the non-communicable diseases, including diabetes increasing, those are therefore also triggers for TB. And the reason I'm raising that, Mia, is that we know that the lifestyles of people are changing. People are moving more and more to fast foods. So the nutritional status of people are also decreasing. So we need to figure out how we can improve the way people both produce and consume food. And that's going to be more and more difficult in the context of climate change, as Kingsley has just mentioned. So we need to think about this in a much more complex way. And as Kingsley said, there is no, linear relationship between these things. It's kind of multifactorial, which means that we've got to research these things far more and have a far more intersectoral plan to deal with these things. So the health system on its own, even if we're looking at the outcomes of climate change, are unlikely to be able to mitigate the impact of climate change. So we need a far more intersectoral approach to it, whether the outcome is TB or HIV or diabetes or whatever. Thanks.
Thanks, Yogan. Just to jargon here a bit. So is what you're saying that if there are long periods of droughts and there are extreme weather events, many people may lose their livelihoods, and then some people would be poorer, and if you're infected with TB, you don't necessarily develop the disease, but if you don't have food, your immune system would be weaker, and then you're more likely to get TB. And if people with HIV then can't access their medication, there will be more people with HIV who also get TB, because that's the most common illness that you get with TB, right?
I think you did it much better than I.
So what about mental health? You're a psychologist by training. What will all these floods and heat waves do to, and also the anxiety that, as Nick mentioned earlier today, that we have 5 years to reach goals, to see if we can do something about climate change and all that climate anxiety around it, but also what happens to your mental health just generally because of these things?
So I think the first thing to say is that many people currently have poor mental health. The stresses of everyday life, even without climate change, are very significant in today's context. So people's mental health generally, in the 21st century people are very vulnerable. So laying on the concerns, the stress of climate change on already vulnerable people is just going to make people's mental health less resilient. So, our starting point is not great. I think that's the first. The second is that it seems like young people are more concerned about climate change than older folk. I guess because climate change is one of these insidious things. It's like diabetes and hypertension. It's kind of hidden. It's not as obvious. So you don't worry about it as much as if you're older. You don't have much longer to live, and you think, well, I'm going to die before this thing becomes a big issue. But we are not investing in what's likely to come to protect the mental health of young people, and hence young people worry more about things like climate change. And there are concepts like eco-anxiety and eco-depression. And all that means, to de-jargonize in your words, is that people get more anxious now than previously about droughts, and cyclones, all of these natural disasters. But I must say, these natural disasters are not quite as natural as we make them out to be, because human action and human inaction are causing many of these climatic changes. So, which means that we should empower young people to do more about adapting and mitigating climate change. So what's the antidote to eco-anxiety and eco-depression? Is empowering young people with information about what they can do themselves and what they can do in their communities about mitigating and adapting to climate change. And I think that's what we need to focus on, as much as the pathologies that relate to climate change, like increasing anxieties and increasing depression.
Thanks very much. I'm going to give this mic to our next speaker, who is Azeeza Rangunwala, and she's a medical scientist, and she works at the nexus of climate change and health at the environmental justice organization GroundWork. And she's also a global senior Atlantic fellow for health equity. Now, one of the things, Azeeza, that things like pandemics and moments of crisis do is they magnify the world around us. They show us what we're doing right and what we're doing wrong. And we saw during pandemics like HIV and COVID, how inequality is highlighted because we live in a society so ravaged by it. And you are a health equity fellow. How are we going to address climate change within this context of inequality?
Thanks, Mia. So one of the most important things about looking at climate justice lens is looking at health equity, because health equity is paramount. We saw during the pandemic that our health systems were not ready. But not only were our health systems not ready, basic service delivery was also found lacking. And health is not just a hospital, it's not just a clinic. You can have your climate resilient healthcare facility with solar panels, with all the medication you need. But what happens when the road washes away? What about our infrastructure beyond the public health infrastructure? Although I do agree that our public health infrastructure needs considerable investment to become climate resilient and to serve populations that are most vulnerable to risks such as extreme weather events, heat stress. I think we've seen in KwaZulu-Natal with the floods that happened twice in a row, where patients and healthcare workers could not go to work and patients couldn't access clinics because the roads were completely washed away. HIV and TB patients could not access medication. They could not access preventative care either. So the health system is just as sick as the patients that come for healing to the health system. So how do we heal the health system to ensure that health inequities are addressed? Because we're already living in a very unequal, I mean, South Africa's Gini coefficient is like super high, and we keep talking about inequities, but what do we change? How do we change that system? And it's not about changing just the health system alone. It's about the quality of water. I mean, there were traces of arsenic found in Guyana in our drinking water, the water you drink, the food you eat, access to electricity. Load shedding is another way that inequalities are also present, because certain areas get load shed longer, certain areas get load reduction above and beyond load shedding. Hospitals are not immune to load shedding. And we're sitting on this thing where we're just balancing in the health system of, oh, we hope something bad doesn't happen. One of my colleagues in Mexico City said that during COVID, the hospital's electricity shut down completely, no backup. 70 ventilators shut down and people died. How do we prevent that from happening in a country like South Africa that's water scarce, energy scarce? And how do our health systems make sure that people also have food security? Because food insecurity, like you mentioned with undernutrition and malnutrition, how do people take these? The medication is you need to be hydrated to take medication, you need to eat healthy food. And you say people are eating fast foods and some people are actually eating no foods as well. Early childhood development, stunted growth, and we need people to be healthy, to house a healthy body, a healthy mind, and also have levels of health literacy, which I think health journalism plays a big role in, is encouraging health literacy in community-anchored resilience. Things like how they say we can learn lessons from COVID for TB, but I also think TB taught us things about COVID as well, how to handle it, and it helped us mitigate it. So thinking of how do we implement policies? We have these great policies, how do we implement it? You know, strengthening the community health workers' presence right now in South Africa is something we have that other countries don't have. Okay, maybe Cuba has better, but I mean, we have community health workers. We need to take care of them. We need to make sure that they are equipped because they are actually community anchored. So I think starting with something like that would make a world of a difference in the health system alone, because they are there, they are present in the communities, they live in those communities, they understand communities. And we talked earlier with someone about Ubuntu. South Africa has that. People are coming from all over the world to come and study Ubuntu in South Africa. And I think we need to cultivate it more and work on our health system to, I think when we use the word decolonize, people think, oh, it's so political. But if we decolonize our health system, we're talking about indigenous knowledge systems. We're thinking about community health and how people can actually support each other. So I think for me, that would be the first starting point. And obviously health having a major seat in any climate change negotiation that's on the bigger, higher level, and also health leading in the just transition in South Africa.
Thanks very much, Azeeza. We're going to move on to the Health Department, to Bono Nemukula, who is the Deputy Director at the National Health Department, where she is responsible for climate change and vector control and air quality. All of those things relate to climate change. Before I ask you what are you going to do? I want to know, have you seen any of these signs that Yogan and Kingston have mentioned? Have you seen more people not adhering to their HIV or TB treatment? Have you seen more cases of TB that you could think could be related to climate change, more respiratory diseases? What's happening?
Thank you, and happy birthday to Bhekisisa. And thank you for the invite. I think one will start by saying one wishes to be like Yogan when they grow up, who will be able to have more information and access, give access to Bhekisisa in terms of that particular information. I think in terms of our district health information system, some of the conditions, I'll speak specifically for those respiratory tract infection, because we had actually to respond to one of the questions that was raised with the parliamentary question regarding airborne diseases, especially for the Highveld priority area. I think because you are in health journalism, you know the court case that happened in that particular area. One of the questions was that we need to be able to present the data in terms of respiratory tract infection. But when we look at our DHIS system, it was not easy for us to say what we have, it is as a result of air pollution. So it becomes difficult to be able to quantify and say this is as a result of air pollution, this is as a result of maybe other variables. So I would say we still need to do a lot more. This is one of the area. We actually have two committees within the department. We've got a committee on air quality and health focus group, which we actually established in 2022, and we meet on quarterly basis. The same with National Climate Change and Health Steering Committee, which actually we have a whole lot of stakeholders. groundWork, Azeeza is one of them. I saw there's another colleague from MSF who's from there. We have researchers who are also sitting there. So one of the area was that we need to develop indicators that will actually give us a picture in terms of be it climate change impact on health. Because now we recently received the burden of disease report in 2022, and it was ranking a respiratory tract infection as #2. But then when we wanted to quantify that, it was difficult for us. But researchers, they're the ones who have that information. So what we indicated was that out of the committees that we have, we need members who will be able to assist us as a department to be able to move from policies that are driven without evidence-based research. And hence, we also have subcommittees out of that who are responsible for certain areas. We've got a subcommittee that is responsible for indicators, one for research, one for community mobilization, one also for resource mobilization. So that on its own, we want to be able to say, with evidence that we have, can we be able to come up with policies that will make sense and assist our communities rather than thumbsuck? Thanks.
Thank you, Bono. So do I understand you correctly? So you are still in the process of collecting data to base policies on so that you have evidence and you have committees, but you don't have policies yet.
We actually have policies in place. We just want, in terms of indicators, maybe let me just elaborate. In terms of indicators, we have indicators on the district health information system. But when we look at them, they don't give us more information in terms of us coming up with interventions, especially on climate change.
I just want to interrupt you there. What are those indicators?
I will give one indicator in terms of turnaround time for our ambulance emergency medical services, in terms of be it in rural or in urban area. We saw with KZN when they had floods, and we wanted to ensure that our turnaround time, if we have floods, we are able to assist more people within a specific time. So we have those indicators for EMS. We've got indicators that looks at infant mortality rate, because also that also need to give us some idea, but we feel that it's several indicators that we have actually noted, be it issues of vector, be it issues of communicable disease that have been investigated by environmental health practitioners. Also to indicate that I'm from environmental health, by the way. So we have indicators on quality of water. So it's several indicators. I think all in all, we have 14 indicators that we've identified, but we still feel with the researchers that sit in those particular committees that they are not enough to give us a proper picture. And also on air quality, this is one of my research topics with the study that I'm doing, that it's not so easy for you to be able to say you are separating air pollution related respiratory diseases versus maybe hereditary or others that are being caused by other things.
Bono, has the department looked at its budgets? So when you see the evidence coming in that there are perhaps more air pollution cases and that there's less adherence to treatment and more diabetes that could be fueled by climate change, have you planned on how you're going to increase your budgets in those specific areas?
Thank you. I think one can just indicate that climate change, a program within the department, especially maybe just to say a position that was created out of saying that there is a need for someone to facilitate climate change. It's not something that started a long time ago. If you have seen, I only started in 2018. So there is a lot of groundbreaking that one needs to be able to do. And also to indicate that in terms of programs, being able to coordinate and have all programs within the department, especially looking at, I think Yogan touched base on it in terms of the World Health Organization 6 building blocks. It does not only need to have one particular program to be able to coordinate and ensure that climate change impacts within health it's dealt with. It needs a collective. So this is one area through our committee. This is where now we are pulling all the resources that are available within the health sector to be part and parcel, and for them to be able to see that these impacts, we gave a presentation because we're also rolling out trainings in provinces. We gave a presentation in one of the hospitals, and fortunately, we were actually celebrating World Environmental Health Day. And fortunately, the CEO came to welcome us. But when we started presenting, she felt an interest and she sat and listened. So we presented to say, we need as health to start looking at data. Let's say it's summertime or we have heat wave, and you start seeing that you have a lot of patients who are coming in because of diabetes, because of hypertension. And when you look at your data the previous year versus the current year, you see that there's a difference. You need to be able to start thinking to say, what could be the cause? Is there a relation between heat wave and the increase of non-communicable diseases? So there is a lot that we still need to do also as a sector in terms of ensuring that policies that we have developed, because we have developed the Heat Health Action Guideline, which was approved in 2021, and it's there online on our website. We need to ensure that our health facilities, we train them and they understand and they start looking at early warnings. What is it that they can be able to do? Guidance in terms of education and awareness. Azeeza spoke of community health workers. We have the primary health care ward-based outreach teams. Those are people that we can utilize to educate our communities in terms of all these policies that we're actually developing. Thank you.
Thanks, Bono. Before we're going to move on to the audience for questions, just one last question to you. Yogan mentioned earlier that there is a great document on the health department's website with a nice plan on how to cope with climate change, and the department hasn't really done anything about it. What are you going to do?
I think maybe point of correction. It did not say the department has not done anything about it. We have the National Climate Change and Health Adaptation Plan 2014-2019, which is being reviewed. Actually, let me say we have reviewed. It's undergoing internal processes for final approval, but that does not actually mean that we are not doing anything when it comes to activities that is on that particular plan. And I've indicated that one activity is the steering committees. It is part of the document. The other one is indicators. It is part of the document. The other one is the risk and vulnerability assessment that we've conducted with the support of Department of Forestry, Fisheries and the Environment for all our 52 health districts. So that information is available, especially for the RVA for circulation, if colleagues are interested, just to say, if we are saying you are in Tshwane Health District, what are the vulnerability that people can actually be exposed to as a result of climate change and the vulnerable population. But there is a lot that we are doing. We are just waiting for that final endorsement and then be able to share the document, but activities we are actually implementing currently.
Thanks, Bono. Yogan, just quickly, what is it that they're not doing fast enough?
Well, one of the things I think we need to do is figure out how to take such documents into communities. Community health workers can help. Organizations like Bhekisisa can help. But if you talk to folk in communities about climate change and its impact on their health, I will suggest that not many people would see the connection because it's distal, right? Mm-hmm. It's not proximate. And I think that's one of the challenges with indicators as well. When you ask Bono, what indicators are you using? Because these pathways are not linear, it's very difficult to say X causes Y. So we need to get far more sophisticated in trying to both understand the relationships between climate change and be able to explain it to individuals so that it's easily understood. And I think, your concept of how did you say it? De-jargonizing is going to be very important in taking the documents that Bono spoke about into communities. Because I'm quite sure, Bono, if you give those documents that you spoke about just now to community health workers in the current form, it's not going to be very easy for them to translate it into things that are easily understood at community level in households, etc. So there's a gap between many of these policies and accessibility to people on the ground. And that's what's missing.
Thank you, Yogan. We're now ready for questions from you guys, from the audience. So if you have a question, if you're physically present, please put up your hand and then tell us your organization and your name. If you have a question on Zoom, we are looking at those questions. Soleil from the Bhekisisa team, if you could share the link of that document with me so that I can access it here on my phone. And there are also some questions that some of you who have registered online have already sent. So we're not in need of questions. There are a lot of them already. I'm going to start here with our audience. Is there anyone here who would like to ask a question? There at the back, it is Eva from UNA. It's right. If you could just say your full name and your affiliate, your title at UNA, it's Eva. And do you mind standing up so that everyone can hear you?
Good morning, everybody. My name is Eva Kiwango, and I'm the UNAIDS Country Director in South Africa. So thank you very much, Bhekisisa, and happy birthday. I think at some point we should sing happy birthday. So thank you very much to all the panelists. I think the pathways linking climate change to HIV have been very well explained. And thank you for also referring to the bidirectional nature, how climate change also influences the increased transmission of HIV. So my question is to Yogan. What did you do when you were the Deputy Director General, the Department of Health, to ensure that we integrated climate change into the discussions we were having around HIV, TB, and STIs? Because you transitioned out of that position, just several years ago. And what do you think we should be doing more of in terms of integrating climate change discussions into, the National AIDS Council, the South African National AIDS Council, the plenary discussions which are chaired by the Deputy President, the Civil Society Forum, the strong civil HIV activism that we have, into capacity building, into development of programs around addressing, for example, opportunistic infections, because we know that fungal infections will increase with climate change, into monitoring. We know there's community-led monitoring. What can they do? And into political leadership at every level, and into funding proposals. We're about to start developing the global fund proposals for $530 million. How should we be taking into consideration climate change?
Wow, Eva, that's like writing a book. Answering those questions is like writing a book. But let me give it a shot. So I think the first thing is that we need to be clearer about the relationships and the more proximal relationships between these. When you're working in the National Department, you are concerned about proximal relationships rather than distal relationships, because you're writing for what can be done immediately. So one of the things we were very concerned about, at least when I was in the department, was to ensure that people get tested for HIV and they are put on treatment as quickly as possible, to find the right drugs at an affordable price and get it done. So we weren't looking too far ahead and to look at things outside the health system. Now, is that a mistake? Of course, it's a mistake. Should we be doing it? Of course, we should be doing it. So, that would be my response to the first part of your question. Now, the question is, what do we do going forward? So the first thing is, and, Bono is right. We need, if we are going to be tracking the impact of climate change on health outcomes, we've got to have the right surveillance systems in place. The DHIS is not going to do it for us, unfortunately, right? For many reasons. So we need to figure out not only what indicators we need to come up with, but what surveillance systems we need to put in place. And we can only do that when we have a better understanding of what are the proximal and what are the more distal factors that are going to drive changes in outcomes that are related to not only climate change writ large, but the mediators to climate change. So, we've got to understand, and that's why understanding the pathways are going to be very important going forward. And what we do need is more research on the pathways, more clearly articulating the pathways. So, people like Sharon Fon in the audience, who's based at a university, would need to kind of help us think through the pathways in a much more clearer way. And then develop the surveillance systems, develop the indicators for us to monitor what we're doing. But what we can do right now is to improve people's understanding and awareness of what we already know about climate change and its impact on health. And frankly, I don't think we're doing that well enough. But I think, events like this and organizations like Bhekisisa have a big role to play in providing the information to health professionals and to communities, as well as the private sector, who are the biggest emitters of greenhouse gases, right? In terms of production of food, transportation, and the rest of it. Thanks.
Thank you, Yogan. I'm going to ask one of the questions that we've had on Zoom, and I'm going to ask Kingston to respond. Someone is asking, so if there is treatment interruptions during droughts and during floods, how do we deal with treatment differently to help people to adhere?
Well, thank you so much. I think, first of all, the first thing to think about is what is the context within which these people live in, and what are the things that challenge them and make it difficult for them to engage in treatment. And I think from our understanding that their context, their environments, the poverty levels, the lack of access to water, all of those situations make it difficult for people to maintain treatment or to go out for treatment. So I guess the first thing would be to integrate HIV interventions within a whole systems approach that involves addressing those drivers of contextual vulnerabilities. We noticed, for example, people did not have access to water, and people complained a lot about water tankers not coming to their communities, or they're not being readily available to people. And that becomes a rule, for example, for government to make sure that people have boreholes that work, pipe water systems that also work. And also just the other aspect of it becomes to make mobile clinics some things that work much more efficiently, because during drought or during the context of floods as well, there are those challenges that make it difficult for people to access the healthcare facilities. So mobile clinics that are more accessible, and even situations in which people are able to use those systems to address other health challenges, so that, for example, where you have stigma, which makes it difficult for people to actually go for testing as well. If you have other services that are provided through those mobile health facilities, those become platforms within which people are able to engage the system. Thank you.
Thanks very much, Kingsley. Azeeza, I want you to just chip in here. You've spoken about community health workers. How can we use them to get people to better, not just adhere to their treatment, to get their treatment when the roads aren't there to get to the clinics?
So in different discussions about how do we get medication to people, some people thought about ways of getting drones to deliver medication, which is happening in some parts of the continent already. However, that is reliant on someone knowing that the drone is coming to them and who's it meant for and who gets it, right? So, I mean, that's obviously something that we can think of. But when you're thinking about community health workers and then being able to dispense medication, I mean, perhaps we should look at how, especially when it's chronic medication meant for families, that community health workers can go and ensure that there's enough. Because what happens is also people start sharing medication in the communities because there isn't enough and they're not sure if they're going to do a 3-hour trek through rivers and mountains to get to a clinic to get their refills. And also those who can't get their refills remain stuck. But there's also these, I think the Pillay box that the Health Systems Trust has, where there's a little, mobile containers around, and maybe the use of Pillay box with the community health workers to kind of get everyone their medication and ensure that there's power in those boxes as well. I think those are lots of innovative solutions we can think about, but obviously context specific.
Thanks, Azeeza. I would like to go back to our audience. I see a hand over there. Could you tell us who you are and what is your organization?
Hi, everyone. I'm Candice Homa, and I'm from Doctors Without Borders, and I am the Access Campaign Advocacy Advisor. So I'm actually coming from the access to medicine space. So I just wanted to understand just the link, and perhaps this is more of a question posed to Dr. Yogan. I just wanted to understand the link we see between the work done in the access to medicine space to ensure the availability, accessibility, and affordability of medicine, but also encouraging adapted research and development that would be, accessible for communities, and how this, the work that we've done in the access to medicine space, intersects with climate change. I think during COVID, we saw a lot of inequities on access to medicine or medical tools. And, I think also just the rise on discussions around local production. And just wanted to understand how that work can also be used to mitigate some of the issues or concerns that we're seeing on the climate and the impact that it has on health. And also just the discussions that we're seeing also on the pandemic treaty. I haven't really seen much of a lens on the climate, climate lens. And I wonder if we should be advocating more for, an approach that also looks at, a climate lens when it comes to discussions on the pandemic treaty that would initially, impact our response to pandemics, which also is climate related. Thank you.
Thanks, Candice. Yogan, yes, let's get you. That's a lot of questions. So maybe if we stick to the treaty part, should we involve climate change there?
You know, one of the challenges, Candice, is, you know, if we talk about climate change affecting everything, it becomes like a nothing thing, you know, because it's not specific enough. So the key question is, you know, what about climate change that affects X? And what can we do about it? I think is probably one way to think about it. Because it's like integration. Everybody agrees integration is a good thing, or community participation, or sustainability. You know, these have become buzzwords. Now, we don't want climate change to become a buzzword. We need to figure out what is it about climate change that affects access to medicine, and how is local production related to it? Now, local production in and of itself is a good thing, right? Because you want security of supply. However, in order to get security of supply at an affordable rate, because you need your medicines to be affordable and of good quality, right? You need volumes. Now, if you don't have volumes, you can't produce things that are affordable. So it's a much more complex. You know, I've discovered that, you know, when I was in the department, we were gung-ho about local production of ARVs until we looked at whether we can afford to produce them and afford them at the prices we could get these products from India and China. And then the question was, can you produce APIs, the active pharmaceutical ingredients in your country? And is it always a good thing to do that, noting how toxic these things are? You know, if you look at parts of India and China on the groundwater, for example, and how polluted the groundwater is as a consequence of API production, it's terrible. So you've got to worry about the environment at every level. So, you know, the One Health approach, I think, is a good approach to take, even in the context of climate, that we've got to worry about plant health, environmental health as a consequence, animal health and human health all together. So when we think about local production, we've got to think about a whole bunch of things. Do you have the volumes? Can you produce the APIs? Can you sell the product at a price that you are producing it at? Even if you are a state-owned manufacturing company, you've got to at least break even, right? So there are a number of complexities. So, you know, the move now is to more regional production. So when we talk about local production, it's more regional production, because then you can have economies of scale. So what we need in Africa is we need the African countries and heads of state to come together and say, we can't all produce ARVs, for example, or anti-malarials, or, you know, anti-cancer drugs or whatever. We need to regionalize it, because what each country wants to do, they want to produce these things because of, you know, patriotism, sovereignty, you know, there's also ego attached to it. But we can't all produce it. So we need to think more about regional production. But what you're absolutely right about is that Africa needs to have security of supply. I mean, we saw that in the ARV space. We are still seeing it in the ARV space in the context of cabotegravir, for example, right? Long-acting injectables for prevention of HIV. We still don't have the product. It's available in the north. When we can get the product, we're not going to be able to afford it because it's too expensive. So we saw it in 20 years ago. We're still seeing it today. So we need to figure out how to bridge the gap, but there are complexities involved. Thanks.
Thanks, Yogan. Bono, the South African Medical Research Council is on you, because they heard you want indicators, and the burden of disease research units say they are starting to look at the association between non-optimal temperatures and mortality, and they would like to engage with you on that research. How do you think the health department can engage in such research?
Thank you. I'm just wondering who's asking that, because we've got two colleagues that we work with who are in our committees. It's Prof. Karadi Wright and Dr. Tandi Kabatwa.
Not those two.
Oh, not those two, but already we've got those working relations, so it's not going to be difficult. They just need to extend a hand we are there to assist. We've got actually several projects that we are working with MRC in terms of climate change. So we will definitely engage. Thanks.
We will also pass those names on to you after the panel. There is a question online for you. What proactive changes should healthcare workers on the ground be making now to mitigate the effects of rising heat levels on our sick patients?
Thank you for the question. As I've indicated, we are engaging healthcare practitioners. And I think one can indicate that it's not possible to have all of them in one room. What we were actually doing was that we will have 50 different stakeholders in a physical room, but also have others joining virtually per particular province. And what we are, how we were structuring our training was that we'll have South African Weather Service presenting in terms of projections of heat. Then we have Department of Forestry Fisheries coming in to say, what is it that they're doing in terms of supporting us? Because we don't have funding as health when it comes to issues of climate change. And we will then have provinces and municipalities also indicating what is it that they're doing in terms of climate change, because we have champions within provinces and municipalities. Then we present our document. But the training is specifically for healthcare workers. And what we also have, besides presenting the plan, attached to the plan, is education and awareness material that actually we are presenting to say we need our healthcare workers who are especially on health promotion and our community-based healthcare workers, our warbot teams, to be able to take such to the community, because we are sitting at policy development, but one of our responsibilities to ensure that we educate and capacitate people for implementation. So that is what we are doing, but we know that we have not reached all healthcare professional workers, but that is what we will be able to continue. But at the same time, what we were saying was that we are doing train the trainer to ensure that those who are trained within the provinces and municipalities go and train their other colleagues to ensure that we start implementing such. We want to avoid instances of the 5 farm workers that died in the Kakamas area in Northern Cape, because there is a lot of mitigation, adaptation measures that we can be able to do. As much as it's difficult for us, or it's impossible for us to say we are reducing temperature, we need to be able to say, what is it that we can do in terms of the temperature that is rising? So there is work that is being done. I think what we also, as a closing remark in terms of our training, we always say each municipality that feels that we need to come and train other people, please reach out. We will be able to come and do that. Thank you.
Thanks, Bono. We have time for one more question. Sharon van there. From Wits's Public Health Department, and then do we have another one there from Kate over there? Let's go to Sharon quickly, and then we go to Kate.
Thanks very much for a very stimulating panel discussion. My name is Sharon Fon, and I'm from the Wits School of Public Health. I wanted to make a few comments. Firstly, Bono, I think one of the things you just passed by, but I want to congratulate you on, is your work with the Department of Forestry. One of the biggest challenges in government is working across departments, and it's no small feat to have done that. My hat off to you for that, and I think we should see more of that. And
can we get another mic to Sharon? It doesn't seem to work.
And I think that fits in with Yogan's One Health comment. I think we have to have a lot more of that. And so I really want to acknowledge that you have achieved that. The second point I wanted to make is something that hasn't been discussed here. I understand that we're very much focused on what South Africa should be doing in South Africa. But I think that we also have to think about the determinants of determinants. And one of the questions there is, what is driving climate change? and to be very clear that we do contribute to it and we do have a responsibility in relation to it. But we also have a responsibility to call out the biggest contributors to climate change. And if you have a look at any graph of those contributions, South Africa is a tiny squeak. And then you have Europe, and then you have the US. And let's not forget those international fights that we should be fighting and we should be calling out. There's a lot of change that's required that actually puts us in the position of advocates for international change. And I think the question of responsibility is important, and it comes to the question around access to drugs, and it comes to the question about affordability of regional production and sharing. We need to have functional institutions. We don't have functional institutions in our own country. We can question the functionality of the AU. We can question the functionality of SADC, of ECOWAS. All of these have to be much less bureaucratic, more action-orientated, more doing things. So we also have an activist role to play as individuals, as organizations, as NGOs, as universities, and even our government has to take a more activist role and take some responsibility for doing these kinds of things. I'm old, and I know that the World Trade Organization and the intellectual property rights, people think these things have been here forever. They haven't. They are new, and they don't have to be here. We could have a different world order, and some of us have to be fighting that fight as well. The two last points I want to make is, the proportion of the national fiscus that goes to research is just not enough. And I'm very keen that that is increased nationally and on the continent. We have a lot of partners who do fund our research, but if we don't have skin in the game, why should they put their money into it? And we need to put more money into that. And I want to give you one example that's so simple. People are saying, what can we do on the ground? In South Africa, we have a very long and quite dirty history of understanding heat and work, because the one thing we did put money into was doing research to get people into the mines to dig out gold. And what we learned from that is how to acclimatize people to working in heat. And there are really very simple answers, and they can be implemented in the Northern Cape right now. And those are access to water for workers, access to regular breaks. They cannot work an 8-hour day, and access to shelter, treed areas. If there aren't treed areas, build a shelter so they can be in the shade. And these are things that can be implemented right now. And it comes out of research. And I think that those kinds of investments are also important. And I want to take my hat off to you and wish you happy birthday and commend you for the great work that you've been doing.
Thanks so very much, Sharon. And you've just answered one of the questions of our online participants about what can we do to help workers cope with the heat when they do physical work outside in heat waves. We have time for one more question, and Kate Skinner there at the back had one.
Great, thank you. Yes, I'm Kate Skinner from the Association of Independent Publishers, and it's an organization that looks at community media. And we have a number of members across the country, 200 odd members, covering all the different languages in the country, and basically print and online. And it's actually two questions that I've got. Brief questions. One to Bono, sorry, you seem to be getting a lot of questions, obviously. But it's just to say that, if we're wanting to get a lot of this information out about, the climate crisis and health, we've got to get it out to community media, because that, community media, along with kind of the SABC, it's basically the media that is in small towns, in rural areas, in the languages that, the majority, of course, of our population speaks. But we can't do it in the kind of traditional way of just kind of, sending out a few press statements, hoping that information is going to get there, that it's going to land. And I mean, I like what Mia is saying about dejargonizing. That's absolutely critical, but it's also translating it into those languages. But further to that, and this is always a tricky issue, it's about money. I mean, you cannot just be putting statements out there and even having like a few press conferences. you've actually got to think about how do you put money into those publications to actually get those messages out. It's really, really critical. And the other thing, it's actually a question to you, Mia, around Bhekisisa, and it's saying, you know, there should in fact be a whole lot of relationships and partnerships between Bhekisisa with all its incredible information and community media. How are we getting that information out to the different community media kind of publications so that, you know, the excellent material that you produce actually does get out, you know, further, wider into all the different communities and into all the different languages? So thanks.
Thanks, Kate. You start off, Bono.
Okay, thank you. This is one of the work for the subcommittee that deals with community engagement under climate change. We had our first meeting and we were discussing actually researchers. I think the engagement that was held in University of Pretoria, it might be 2 months back, the issue of El Nino coming in to say it's going to be hot. What is it that we actually need to do? So we have been looking at such a proposal that you have raised to say, how do we then reach out to our different communities in their right languages? We have actually benchmarked with how Kenya is doing it. They are not only looking at giving messages through, we have seen, I think, through media or through leaflets, printed media, but they are also using an avenue of through SMSs, because it's not for them. What they have actually looked at is that it's not everyone who've got access to network or internet or a phone that can be able to get your WhatsApps and all. So they utilize SMSs. So this is what our communication office within the department is actually looking at together with the subcommittee. So there is some work that we are doing, but I think we are happy to say Bhekisisa will also come on board, because I think this is not something that is a one-man show. It needs all hands on deck. It needs all of us to be able to influence people to understand issues of climate change and health within their respective places. Thank you.
Thanks, Bono. Thanks for that question, Kate. So, you know, I learned 2 important lessons during COVID about communication. And one is that accurate information is pretty useless if people can't understand it, and that's where the de-jargoning come in. And then the second one is you can have the perfect message, but if it's not distributed on the right channels, it's also pretty useless. So you can't pretend that TikTok doesn't exist, or that the media isn't evolving, or communication isn't evolving into social media, and just say you're not going to do it. You're going to have to adjust to that. Now, when it comes to Bhekisisa and our stories for community media, something that we've done, we've opened a special page on climate change reporting on our website. So if you go to the website, there's a special report. And one of the roles that we can play is to make it easier for other media, including community media, to understand the science behind this, because that's something we do well. We break down the science, and we try to do a lot of explainers. If you go there, you'll see we've done a number of explainers on how does climate change impact on health, but also broken it down to impact on TB, or impact on, we're soon going to do diabetes and food insecurity and that sort of thing. Our stories can't really be translated directly into other languages because it's written in a mode that's not going to work for community media, but we can most certainly play a role in making it easier to understand it. And we have a TV program now that goes out every month on the last Sunday on ENCA. I don't know if John Bailey is still here. I think he had to leave for deadlines, but he was here earlier. It's the managing editor of ENCA. And it's also on our YouTube channel. And tomorrow our program goes live on the impact of climate change on health on our YouTube channel. And we also do print stories. We chop that program up and make it easier to understand. And that is stuff that community journalists can use as well. Many of the interviews are really, really simple to understand and can be used to quote in your own stories, as long as you just say where you got it from. So that's what we're trying to do. On that note, I'm going to ask each panelist just quickly
that we can end. Obviously, climate change is a very complex issue, and there are lots of things that we're going to have to figure out along the way. But if there is one thing that we can do immediately and that you can implement, what is the thing? It can be a small thing. For instance, learning HIIT lessons, like Sharon has mentioned. What is it that you would do?
You know, the curious thing about the HIIT thing is that it's already in labor regulations. So, you know, it exists already in our labor laws that you need to look after people when it's, you know, in terms of health and safety issues. So the first thing to do is to implement things that are already in law and already in policy, because we have lots of policies. Bono has mentioned the HIIT document already. We need to figure out how to take what we already know into communities, but in ways that not only people understand, Mia, but also people can do something practical with. Thanks.
Thank you very much. I think from my perspective, we need to put the human being, the individual, into planning for climate change. Coming from vulnerable communities or key populations, you realize that each individual has something that affects them and makes it difficult for them to maintain treatment. And so interventions or policies should not just be looking at things from let's say just systems approach, but then think about the person, the human being who is affected by climate change and who that forces them to behave in a manner that would put them at risk at HIV. Thank you.
Thanks, Kingsley. Azeeza?
So just as the last one, just go back to the health facilities. I just wanted to mention that the Global South has to think about resilience and the Global North has to think about mitigation, which is lowering their carbon footprint, like Sharon mentioned. The same cataract eye surgery in the UK uses 180 kgs of CO2, whereas in India, they use 6 kgs for the exact same cataract surgery, 6 kgs of CO2. So there are some things we are doing well, that we can continue doing well. And then there are some things that we just have to enforce, like our Occupational Health and Safety Act is actually a very nice act. It's just that we need to think about the social part of it. We are also recovering from apartheid. Let's be honest about that. And that's why people are dying from heat and don't have shelter and are not looked after as a labor workforce. So I think looking at enforcement is a good one, and looking at our healthcare system, how do we get it to be climate resilient, and also basic service delivery. I think that's very important.
Thank you. I think for me, looking at the World Bank study that was done recently in terms of urban heat and the presentation in terms of, if you look at, they were looking at Sentin versus Alexander at an aerial view, Tembisa versus Kempton Park. And your feel of temperature, remember when projections comes from South African Weather Service, it will say for Kempton Park, which will include Tembisa, it will be 32 degrees, for instance. But the way you will feel it in Kempton Park will not be the same as in Tembisa because of how the places is structured. At an aerial view, you are able to see that in Kempton Park, there are a lot of trees versus in Tembisa. So I think she spoke of the apartheid era and how our houses are structured. So with that being said, what one can be able to advocate for, it's for us. I know that as most of the time when we get to buy properties into these urban areas, we cut trees, because we think that it will be an easy access for criminals. But we forget that there is a reason why we have those particular trees. The same with people who are in vulnerable settings, informal settlement. What research has indicated was that when it's hot, your sheds, corrugated iron sheds, you feel the temperature at the highest level. And the only thing that can be done is that we insulate that particular property. I know that there have been arguments to say, health, are you coming
to provide such. And we've indicated that we are not a stakeholder that will actually support, or we can support, but we cannot be able to provide such. We need coordination and integration of different sectors to be able to ensure that what we have put on policy get to be realized. I'll pause here. Thank you.
Thanks, Bono. So planting trees, implementing the policies that we already have, and putting human beings at the center of our decisions. That brings us to the end of our panel discussion. Thank you very much for our panelists for availing themselves, for being patient, and for sharing all your expertise and knowledge. Just before we go, if you're a journalist and you've joined us on Zoom or YouTube, we're going to try our best to have the recording of this discussion online on YouTube by the end of today. Just needs to render first. And by tomorrow midday, I'd say we'd have a page on our website at Bhekisisa with a summary of the discussion. And if you need any explanations on climate change, there's a special section on our website, and there's also our TV program, Healthbeat, that will go live on our YouTube channel tomorrow with scientists breaking down many of the things that were said today. Thanks very much for joining us. And sorry, one thing before we go, if you're a journalist and you wanted to speak to one of the panelists and wanted to do an interview, you can contact WhatsApp our program associate, Saleh Crooks-Gisano, and her WhatsApp number is 083 286 7084. That's 083 286 7084. And it's also in the chat box. I think Sola has put it there on your Zoom screen. Thank you very much for joining us, and I hope we can take this discussion further in the media.
Thank you.